this way. So for those of you that are online, everything holds. There happens to be about 20 people in person, which is great. Remember that you can raise your hand if you want to ask a question online. And then for those in the room, Dr. Girard will repeat your question because you don't have microphones there. I want to acknowledge that we're on this beautiful Friday morning on the West Coast, hosting this session on the unceded ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. And I think you'll all agree that it's a quite beautiful day with the cherry blossoms and the tulips and the daffodils, and it reminds you that there might be hope in the world, and promising, and just maybe, because listening to the news was not a hopeful thing as I drove in this morning. Province-wide rounds is a collaboration between UBC and BC Renal, and importantly, all of the health authorities contribute both by participating as well as by giving talks, and we have an amazing partnership with our industry group as well, and I think it's proved to be a really excellent collaboration. And so it gives me a lot of pleasure to be able to introduce Dr. Louis Girard, who is from University of Calgary. He's a nephrologist and clinical professor of medicine within the Division of Nephrology.
Recording in progress.
And he focuses on immunology and infectious diseases in chronic kidney disease patients. He's the medical director of the GN Clinic and Apheresis, and he's recently established and is the current program director of the GN Fellowship at U of Calgary. Very involved in therapeutic clinical trials and has several peer-reviewed publications in the vasculitis space, and was an investigator on PEXIVAS and Advocate. And he's a member of the ANCA-associated Guideline Committee and was an author on the 2020 and 2022 documents. He's got a strong commitment to education. I know he spent a very interesting evening with the fellows talking about interesting cases yesterday, so that was well received by all, and he's meeting with the rheumatology fellows this afternoon to talk about some more interesting cases. So without further ado, I'm happy to learn with you.
Okay, great. Well, thanks for inviting me to present rounds, and thanks for the introduction. It's nice to do in-person rounds, so thank you for everyone for showing up. I know sometimes that can be disruptive to your day, but much appreciated. So for those of you that heard me speak yesterday, I'm going to try and stay out of the realm of controversy today, but I'm happy to take those questions for sure. I just wanted to highlight my disclosure here. So the pertinent one is that I have done some consulting in CME with Otsuka, and today we'll talk about avacopan. And also Dr. Levin mentioned the trials that I've been involved with. So the ones listed here are either related to ANCA or have avacopan in them. Accolade, you may not be as familiar with, is a C3GN. And then just because of my biases, I'm one of the authors on the guidelines that I'll be speaking about today. So for this session, what I would like to do is revisit pathophysiology of ANCA and start integrating that into the understanding of disease, because I think, you know, as glomerular nephritis doctors, as we progress through our careers, it's really understanding these mechanisms and how the medications work that enable us to understand how to select therapy, and sometimes it'll inform therapy as well. So we'll go through existing therapies and we'll look at the updated paradigms in terms of guidelines there. And then we'll speak a bit about emerging therapies in this space, which is a point of interest. So I did want to introduce another patient of mine. So this is a 44-year-old gentleman, and he has known anti-PR3 vasculitis by the time he's referred to us, but I'll go back to his history. So in 1995, he became severely ill, had pulmonary hemorrhage, had glomerular nephritis, episcleritis, arthralgias, and ENT. So very classic presentation for PR3 positive ANCA. And as was consistent with the time, he was treated with cyclophosphamide and steroids. He relapsed in 1997. And so and his relapses are usually ENT and kidney. So there they give him cyclophosphamide, steroids, and some methotrexate, which again would have been pretty common at the time. And that's continued until about 2000. In 2009, he moves to Canada and has, again, a classic relapse for him and gets cyclophosphamide methotrexate again, which is continued until 2016. 2016, he flares again. And so at that time, they give him rituximab times 2 doses, put him on methotrexate and a more prolonged course of steroids. In 2022, they stopped the steroids. So you can see, you know, as we might think about managing this person now, he's on steroids for a long, long period of time and is left on methotrexate. In 2023, this is when he's first referred to our clinic. He again has an ENT and GN relapse. His biopsy was a little bit strange, meaning he was on methotrexate. And so I think some of the immunologic findings were maybe muted by the background immune therapy, but he was showing us evidence of focal necrosis, and he had nephrotic range proteinuria at that time. And so rightly so, this patient asked me, why does this keep happening to me? And basically, can you fix me? Can you guarantee me that if you treat me again, this isn't going to keep happening to me? So we'll go through that journey with him. So let's take a step back to a bit of basics. And so, you know, I always say this not just to be obvious, but the N in ANCA is neutrophil, right? So this is a disease that goes through neutrophils. And myeloperoxidase and proteinase 3 are normal protein components of the neutrophil that it uses to attack either foreign cells or damaged cells and that sort of thing. And those are, of course, what leads to the development of the ANCA antibodies. We did talk a bit about atypical ANCA yesterday, and so there are situations where patients may develop vasculitis, but they're PR3 or MPO negative. However, they have immunofluorescence that's positive on their blood tests, right? So lactoferrin would be one of those ones. We talk about something called LAMP2, which I'll talk about in a little bit. And I highlight elastase as well. So I think one of the fellows or maybe one of the attendings had mentioned someone who had a cocaine-induced vasculitis. And so that's common to see in anti-elastase. So those are some of the targets that occur. So when we look at this very simple diagram, we're going to start talking about pathogenesis. And I'm going to come back to this in several different ways. But as is the case with many autoimmune diseases, there's often a trigger. And, you know, yesterday I presented the case of the gentleman who had preceding symptoms and then got a COVID vaccination and got worse. And I never meant to imply that COVID caused that. I think the patient had the disease that was grumbling, and then this immunologic trigger activated it. So oftentimes we see grumbling disease and some sort of trigger sets it off. And then this leads to priming of the neutrophil. So the neutrophil will express things like PR3 and MPO. And I'll get into complement a bit more in a minute here. But complement is key to the priming of neutrophils and the ongoing activation of neutrophils as well. So what happens in patients who don't have ANCA is that occurs, and then the neutrophils are able to settle down and go to rest. But for whatever reason, and this part we don't really understand, and I'll get into it a little bit here, is these patients will have preformed ANCA antibodies. So these antibodies will then bind the target, typically MPO or PR3, and they keep the neutrophil in an activated state, so it's not able to go to rest, and that ultimately results in endothelial injury and what we typically think of as vasculitis. There's a lot of things, if you read and you're a basic scientist, which I'm not, about nets and damage-associated molecules and all this kind of stuff, and I don't feel super competent to speak about that, but just suffice it to say that this pathway is very complicated. So the first question is, you know, why do patients make autoantibodies to MPO and PR3? And again, the easy answer to that question is we don't know. But if you read about this, you'll come across LAMP2. And for a while, LAMP2 was a big thing, and it seems to have settled down. So this was one of these atypical ANCAs. And it turns out that there's a lot of homology between LAMP2 and the Fimbriae on bacteria, in particular E. coli. And so some patients, when they develop an E. coli infection, will develop antibodies to the Fimbriae, but also those antibodies then cross-react with LAMP2 because of the homology, and then the patients end up developing vasculitis. So that's one of the ways in which you might develop an autoantibody. Okay, pretty simplistic view of things, but probably one of the easier ones to understand. If we want to get into things that are sort of more complex, we've talked a little bit about environmental risk factors. So I talked about E. coli just now, but in ANCA, particularly in PR3, there's an association with staphylococcal infection, and particularly staphylococcal nasal carriage as well, that may incite some of this. But over here would be another contributor, is the genetic risk alleles. And I remember, going through medical school and residency, and we actually sort of discounted genetics a lot. We didn't speak about it a lot, but I think part of it is that we didn't understand it that well. And now the way in which we can investigate patients and do, these high volumes of sequencing, we're now able to understand these patients better. And it turns out that in certain patients with ANCA vasculitis, they actually have genetic predispositions to developing the disease. And those genetic predispositions may have to do with things like neutrophil overactivation, but they may also have to do with generation of these autoantibodies. And then the one that sort of hurts our brain a little bit, but I think is important too, is there are these stochastic factors, or what we call random factors. So if you look at modeling around randomness and inflammation, you can see that there'll be like a blip of inflammation and it settles down, and a blip of inflammation and it settles down, and a blip and a blip. But all of a sudden you start getting a bunch of blips, and then it starts to blow up on you, and you exceed that threshold, and you get a super inflammatory process. And that stochastic or even chaotic, if anyone reads about chaos theory, we don't understand very well what leads to that sort of sequence unraveling in that way. And so for now, we think of it as being random. But ultimately, it's a combination of genetic, environmental, and stochastic factors that lead to the genesis of this disease. When we look at PR3 versus MPO, there's also differences there. So if we break PR3 down, there have been genetic risk polymorphisms and alleles that are associated with PR3, and there are some that are associated with MPO as well. When we look at the environmental factors, again, Staphylococcus seems to associate with PR3, but it has been shown with MPO, but there's other things like exposure to silica, for example, or molecular mimicry, which I discussed a little bit with the LAMP2. And then when we get down into the actual diseases, we see different diseases that occur as well. So with PR3, for example, we get the classic sort of upper respiratory tract involvement in granulomatous disease. Whereas with MPO, we can see either renal limited disease or even this grumbling interstitial lung disease that was first well described in Japan. So I think part of the message of this slide is as a person who's participated in ANCA research and who treats patients with ANCA, is that we lump these diseases together because we want to be able to study it in a way that's, statistically and clinically meaningful. However, they are different diseases and they behave very differently. And I think in glomerular nephritis, a lot of this occurs, and certainly in other spaces, but when we call something C3 glomerular nephritis, to me, that means it could be 50 different things that we put under that umbrella. And so this is the situation here as well. And I'm on purpose not discussing eGPA a lot here because we don't deal with it that much and it's not been as well studied, but of course that would be another variant in this space. So if we think about stages, then the patient somehow will develop loss of immune tolerance to the ANCA antigen, and then we start to see production of ANCA by ANCA antibodies by presumably B cells. But then what happens is this primed neutrophil pathway, which has to do with the antibody not allowing the neutrophil to settle down, but then the cascade that happens through the complement amplification loop, which I'm going to discuss a little bit further here. So I think it's become almost illegal now to do a talk without a complement cascade. So here it is. so here it is. But, of course, we have the classical and the lectin pathway, which I'm not going to discuss a lot today, but we think that part of this neutrophil activation pathway occurs through the alternative complement cascade. So as you may remember, we've got the C3 convertase that is always ready to go. So complement, remember, is innate immunity. It's not adaptive, and it's ready to go. So for example, this morning, presumably we brushed our teeth and became transiently bacteremic, but your complement cascade activated immediately and you were good, right? So we want these factors are preformed and regulated. So C3 is the real control of that. And once the cascade gets activated, we generate the C5 convertase, which leads to what most people think of with this as C5 beta 9, which is membrane attack complex, right? So that's the molecule that punches holes in foreign molecules or damaged native cells. However, part of that split product when you make C5 is C5a, which is an anaphylatoxin, and that can send signals to the rest of the immune system, including neutrophils as well. So if we go to the neutrophil, then it's primed, and part of that priming involves the expression of a C5a receptor. So the neutrophil not only can express C5a receptors, but it also can make C5a. So it can auto-stimulate, making that neutrophil more active, but also by secretion of C5a, it can attract more neutrophils into the environment. So what occurs then is you get this vicious cycle of neutrophil activation, complement secretion, and then these neutrophils can't settle down because they're primed by the antibody. So they keep secreting complement, and you get more and more instillation of neutrophil into the vessel and resultant vasculitis. So if we look at the patient, then you get expression of these adhesion molecules. So whenever neutrophils or other immune cells are trying to get into tissue, they actually have to bind the tissue and infiltrate the tissue. So with this, you get expression of these adhesion molecules that result in adherence of the neutrophils to the vasculature. And then you get this cycle of more expression of these molecules, more antibody binding, more complement activation. So that results in increasing vascular damage. So I want to take a sidestep for a second because as I was preparing for this talk, I was coming across this and I never thought about this, but and we can just do a quick show of hands. Does anyone measure ferritin in patients who have ANCA-vasculitis? No one? Okay, I don't either. So, but I might. So it turns out that ferritin is also a marker of neutrophil overactivation as well. And you might think of a disease like hemophagocytosis, for example, right? So those patients get very high levels of ferritin. And so in this study, they looked at about 400 patients, and what they did was compare their CRP levels to their ferritin levels and try and predict outcomes with that. And so it's very interesting because if you look at this bottom red line, those patients are patients who had high ferritins and normal complement. They seem to do the worst. The next line was high ferritin, high complement. The next line was normal ferritin, low complement, and then normal. So normal seemed to do the best, but the high ferritin patients actually seem to do the worst, and even in the presence of a normal complement. What I didn't know, and having practiced medicine for 15 years now, is that I said complement, I meant CRP. So CRP. CRP actually has an anti-inflammatory effect, right? So the idea would be if you have a high ferritin and a normal CRP, you're not benefiting from the anti-inflammatory effect of the CRP. That's kind of the thought there, but they don't know. And they've actually divided it out into quartiles as well. And it looks like the renal survival is also predicted by the quartile of ferritin, with the fourth or the highest quartile being the worst outcome. So, I think it's interesting. And what they did furthermore in this study is it seems like the ferritin levels correlate with crescentic glomerular nephritis as well. So you can see high serum ferritins were more likely to have crescentic glomerular nephritis. So, I think it's an interesting study, and I might start measuring ferritins in my patients now just to get a sense. So I'll be interested to see that. But I just wanted to make that link between neutrophils and ferritin here. So when we look at traditional therapy, I just stole this slide again and added stuff to it. So prednisone really is a medication that's meant to deal with neutrophils. So it lyses neutrophils, it causes them to demarginate and not be able to adhere to the blood vessel. And it also settles down inflammation in a very quick way. I keep telling my patients that one day, by the time I retire, I hope we don't have to use much prednisone anymore. But the fact remains is it's one of our most powerful, rapidly active anti-inflammatory medications. And then when we look at some of the other therapies we would use, so rituximab obviously is B-cell directed. Azathioprine and MMF in maintenance, or you sometimes can use MMF in induction, is probably addresses both of these, but is more leaning towards T-cell directed therapy. And then cyclophosphamide I made bigger here, but I could have probably just made the whole screen cyclophosphamide because it's sort of, you know, a grenade that hits everything. So that's sort of where traditional therapies go. And sorry, I forgot my most important therapy, plasmapheresis, right? So we think it removes pathogenic autoantibodies, but there's probably a bunch of other ways in which it works as well. So let's look a bit at our guideline-directed therapy. And so this is the 2020 guidelines. So again, the recommendations are for high-dose glucocorticoids at the time. Remember, this predates the Advocate trial. And this is the first time we start seeing a bit of mentioning that maybe there could be a preference for rituximab, but the high level is cyclophosphamide or rituximab, okay? They say here that urgent plasma exchange is not recommended for most patients. And yesterday, the fellows are probably tired of talking about plasma exchange now, so we talked a lot about this yesterday, but we can revisit for those who have questions. And then we enter a period of glucocorticoid tapering and maintenance. And so the preference for maintenance in this document was for rituximab and using azathioprine or methotrexate when you can't. So as I was chatting with Dr. Levin before rounds today, ANCA is actually a space where we have a lot of clinical trial data, right? So we've actually been blessed with good clinical trials and decent sized clinical trials. So Cyclops, RAVE, and PEXIVAS really inform the induction, and there's other trials that we can put in there, but those are some of the seminal trials. And maintenance, there's actually been even more randomized data. So there's main RITSAN 1 through 3, ritazaram, PEXIVAS also speaks to this in terms of the steroids, and then the TAPIR trial, which I mentioned yesterday, which is not fully published yet, and we just have the abstract, but just looking at, you know, extending maintenance steroid therapy versus not. Was not part of that 2020 guideline though, TAPIR. So I wanted to move to Advocate quickly, just to talk a bit about how we might be treating kidney disease as well. So as a reminder, Advocate was a phase 3 clinical trial that had about 165 patients in each arm. Patients with ANCA vasculitis were randomized to receive avacopan or prednisone. And I'll show you the avacopan taper, but basically once they were put on avacopan, prednisone was rapidly taken off. The primary endpoints of this trial were remission. So this was not a kidney trial, and I keep saying this over and over. If we were going to do a kidney trial, we would have put in requirements to have more severe kidney disease and generate those events. So patients were excluded if they had GFRs less than 15, or if they were mechanically ventilated. So when we look at the outcomes of this trial, at 6 months, there was non-inferiority. So you see the point estimate here sits on superiority, but confidence intervals overlap. So non-inferiority of avacopan to glucocorticoid. And then at the 12-month mark, we see superiority. We had discussion last night around things in trial design and such that might influence that, but for the purposes of finishing today, I will leave that aside for now. Additionally, avacopan is really meant to replace prednisone. And so the question is, does it do that? And it turns out it does reduce your prednisone exposure very significantly. So you can see the average reduction here in prednisone dose exposure, but also median doses, which are significantly lower in patients who are treated with avacopan. And I'm not going to discuss the glucocorticoid toxicity, but basically a long story to say, yes, there's a lot less glucocorticoid toxicity when you give patients less glucocorticoids. The one thing that's interesting, and we discussed this a bit last night, is the way you're supposed to do this is when you start patients on avacopan, is drop the dose of prednisone to 20 and then taper by 5 milligrams every week thereafter. Okay, so by 4 weeks, they should be off of prednisone. And you could see the controversy last night that generated. There's discomfort with that, and we even look at real world evidence, and in the real world, we're not seeing that rapid of taper. Now, you could say either I'm being a pioneer or I'm not very smart, but every patient with avacopan I put on, I've used this taper. So, people do that for sure. So when we look at GFR, we can see that the patients randomized to avacopan at week 26 and week 52 had greater recoveries in their GFR. And this is always an interesting slide, because when I show it, most people are underwhelmed by it, and they're saying, well, it's 2 or 3 mils or whatever. But again, remember that all these patients with glomerular nephritis also have chronic kidney disease. And so saving kidney over time hopefully would predictably delay end-stage kidney disease, although, we don't have duration of study to show that. But the other thing is that the average GFR in these patients was quite high, right? So we're going from a high GFR that we don't have a lot of room to improve already. So that may mitigate some of that improvement. So if we look at the patients who actually had more severe kidney disease in the cohort, so these would be patients with GFRs of 15 to 20, and the average was 17. And also these patients were predominantly MPO patients. So those are the ones we really fear with bad GFRs and MPO. Usually those don't do very well. They don't recover very well. But here we actually see quite a significant difference in terms of their renal recovery in that more advanced kidney disease population. And as I showed you last evening as well, there's real world evidence to suggest the same thing, right? So one thing, being cognizant we've got learners in the room too, is when you see sub-analysis, it's hypothesis generating. It's a nice thing to see, but it doesn't necessarily prove anything. However, when we start seeing the same signal over and over, then maybe it gives you an idea that this could be a signal. And actually there is an initiative in Canada to explore this question in a formal way through a CIHR-funded grant that Dr. Walsh is the lead PI on, enrolling patients with severe kidney disease to receive avacopan versus prednisone. So that led to the update of the 2022 CANVAS guidelines, where we said that the addition of avacopan can be considered an induction of remission. The Health Canada label, just to point out, says that this should be used in addition to steroid. So it's not meant to be used in the complete absence of it. Has it been used in the complete absence of steroid? Yes. So there were some of the patients who were randomized in Advocate who received no steroids at all. And also Dr. Jane, who's one of the leading experts in the world in vasculitis, has a particular dislike for steroids and has actually treated many patients without any steroid at all. But I think some of that is selecting that patient and is probably more of a grumbly patient than like an acutely very ill patient where he's done that. We also recommended, as per the trial, that you should aim to get patients off steroid by 4 weeks if you use avacopan, and that you should continue the medication for 1 year. And last night we explored reasons why you may want to maybe prolong tapering, or why you may want to prolong more than 1 year. But I'm not going to go into those today. And just to show you that the Canadians aren't maybe crazy, although I don't know if we should use the Americans as the benchmark for this, but if we look at our international guidelines, KDIGO actually says that avacopan can be used, and they actually use the term alternative to glucocorticoids in their guideline. And they say that you can look at patients with an increased risk of toxicity, or patients with a lower GFR may derive greater benefit. So that's actually in the KDIGO guideline as well. So this has certainly changed the way we practice. So that's kind of where we are currently. So I'm going to spend the next section discussing some newer therapeutic areas, and then I'll chat a little bit about what we do in Calgary as well. So again, another simple slide. But when I started, you know, in nephrology, or yeah, I mean, even when I started as a fellow, I actually put the first person in Calgary on rituximab for ANCA-associated. So that was in 2008. So back then, we had cyclophosphamide and steroids, and that was what you did, right? But now we've got all of these options that are coming out. So I'll highlight a few of them. So I did chat a bit about avacopan here, but there are other potential C5 targets. So we know about eculizumab and vilobelimab, which is a C5a blocker rather than a receptor blocker. And I'll discuss a little bit about that biology in a second. When we look at B cells, again, really all we had to talk about was rituximab. But now we're starting to see other ways of dealing with B cells. And so belimumab, you might be familiar with from lupus. There's Bexivas and Combivas that are running, looking at that agent. And there's also obinutuzumab. So there's been a lot of discussion around OB as a more powerful B cell depleting agent, and it's developing data in nephrotic syndrome and lupus with the Regency trial, and also OB-VAS is ongoing as well. And then there's anti-APRIL, and you may be more familiar with this in the space of IgA nephropathy, but there are agents that can address APRIL, and there's also agents that can address BAFF and APRIL together. There was a trial looking at abatacept, which is dealing with T cells, called Abrogate, and it was actually overall a negative trial. And then I just put this up here for EGPA, but there's actually a lot of monoclonals that have been developed looking at EGPA and targeting eosinophils and eosinophil activation and the interleukins there. So if you're interested in this, there's the Mandera, Mira, and Emerge trials that look at EGPA in that space. So really, we've gone from having nothing to maybe not knowing what to do with ourselves, right? So there's a lot of stuff going on here. I did want to just highlight this, and this is pure conjecture, so just remember I said this. But one of the people are trying to explain, why is it that avacopan may have better kidney outcomes than other agents? And so it turns out that avacopan is a very specific blocker of the C5a receptor, and it actually blocks C5AR1, which is the one that's involved in leukocyte trafficking and activation. However, when you activate C5a, you also get activation of this C5L2. And C5L2 is an anti-fibrotic pathway. So nature, of course, is much smarter than we are. And she says, well, if we're going to activate these neutrophils, we should also activate an anti-fibrotic pathway, not to damage our host. But humans aren't very smart. And so when you block this, you know, the idea might be that you actually are improving the neutrophil part, but you're actually upregulating the fibrotic part of things. And so that could be a molecular reason why avacopan seems to work in this situation versus other therapies. But the short answer is it's conjecture, and there's ongoing trials in this space to kind of look at it further. So let's look at even newer therapies now. And now we're going to go down a very dark road, but I think an exciting road. So I think, first of all, again, we can see how things have improved. So in the 80s and 90s, and some of you may remember this and may have even used it, we have a drug called alemtuzumab, which just wipes everything out, right? So you could do that. But then we started seeing the emergence of CD20 therapies, and then we start seeing the emergence. And so you see like the acceleration of therapies that are emerging. But what's starting to come around now is CAR T cell therapy, which has been looked at heavily in malignancies and blood-borne malignancies, but is reflective of a personalized medicine approach as well. So I just want to go through this a little bit. So you can actually do interesting things. So here you can actually use liposomes to deliver medications. And many of us in this room have probably had liposome medication, because that's how the mRNA vaccines are delivered, right? So they're delivered with a liposome. So what you can then do is create therapeutic type of lysosomes. And one interesting thing, for example, is let's say you put an antibody on here to anti-PR3. So you can start mopping up B cells, for example, that are expressing anti-PR3 antibodies. So you can use a liposome to do that sort of thing. And they've started looking at that. And the interesting thing is you can also start pairing it. So for example, you could do CD22 binding molecule, which would attract a B cell, but also one that has an antigen that would bind something that's expressing anti-PR3. So liposomal therapy would be a possibility. The other thing is starting to look at therapies that actually target the B and T cell interaction. So I showed you this on this other slide. There's a lot of therapies that kind of are involved in trying to address this interaction between B and T cells. But what you can actually start doing is developing what's called a bispecific T cell engager. So what this is a molecule that will bring a cytotoxic T cell in contact with, say, your B cell and kill it. So you can do that in a non-specific way, but you could also do it in a way where you would attract the B cell that's actually expressing the antibody that's the problem and get a much more specific type of lysis of the cell as well. And you could do that presumably in the context of immunosuppression or not. And if any of you have seen patients who get CAR T cell therapies, they are at risk of having these cytokine storms and they can get very sick. So one of the ideas would be, can we sort of get things suppressed with the immune suppression so there aren't as many cells to lyse, and then we can go and clean it up with the bispecific T cell engager. And so there's actually a company that's actually developing a bispecific T cell engager for ANCA vasculitis in particular to do this. So I just wanted to step back to CAR T for a second, and then we'll compare it to these bispecific T cell engagers. So CAR T is, one of the things of personalized medicine that's super cool, right? So you take a patient's blood, and we actually do these collections in our apheresis unit, so we get to see these patients. So you take their blood, get their T cells, you transfect it with the gene that you want. So in the setting of a malignancy, for example, you would transfect it with an antibody that attacks the malignancy that you're interested in. Then you reinfuse those cells into the patient, and then that therapy goes and treats the cancer, right? So it's a really personalized medicine because I'm taking your cells, modifying it to attack your cancer and giving it back to you. And there's actually different ways in which you can develop the actual CAR T part of it, and it can actually be done in a way similar to a bispecific T cell engager as well. So CAR T cell therapy can do that as well. So I'm going to skip this one and go to this one. So the problem with CAR T cells is that you actually there's a preparation time that's required to do this. So if someone's super sick, sometimes getting these CAR T cells isn't always a possibility, right? And then you go through this phase of depletion, and then the idea is that hopefully when the naive B cells return, they're B cells that aren't causing your problem. Of course, with this, there are potential problems, including infections from lymphodepletion, failure of engraftment, and there actually have been T cell lymphomas as well that have developed from CAR T cell therapy. So the T cells we give back to you become a cancer, which obviously is suboptimal, right? So some of the things they're looking at is developing an off switch so that you can actually turn the CAR T cell off. But when you do this, and they've looked at it in mice with ANCA vasculitis, if you give them CAR T cell, is that a bad thing? Okay. So if you give
Blue Providence 7 Alpha. Code Blue Providence 7 Alpha. Code Blue Providence 7 Alpha.
So if you give mice CAR T cell therapy, you can actually take them from having crescentic glomerular nephritis to resolution of their glomerular nephritis. So we talked about that. So this is just looking at things just from a timeline perspective. So if you look at their disease activity, when you look at CAR T cell therapy, the timeline to getting patients infused is much longer than, for example, giving them a ready-made bispecific T cell engager. So that's some of the discussion that's occurring there. So how do we put this all together? Well, with this very simple chart. So no, this is really a chart just to highlight the other thing, which I think is really important here, which is machine learning, big data, that kind of thing, okay? So you don't have to focus on this in particular, but what they did in this study with ANCA, and I feel like this space in ANCA is not as well developed, so it's certainly an opportunity, is they looked at about 17 different variables, and then the computer was able to cluster them into categories. And funny enough, the computer is very smart, and it decided 3 of the most important categories were kidney related. So SK was severe kidney, MPOK was MPO kidney, PR3K was PR3 kidney, okay? IMS was inflammatory multi-system disorder. So basically the computer generated these clusters, and then and this was a multinational involvement. So several registries were here from Czech, the French group, Germany, Poland, etc. Okay. And so what they were able to do is, based on this clustering, the computer was able to predict kidney outcomes based on these parameters that as a human we'd probably have a hard time assimilating. So I think this is a basic example of this, but I think this is what we need to do is combine on national and international levels these large data sets to kind of advance both our prediction capabilities, but also the development of therapies as well. So what's the path forward? So the idea here, and this was published, and I like this, but I've added some things as well. So as you have glomerular nephritis, you start doing deep phenotyping with what we call, I'm not going to say it, but omics, right? So basically omics altogether. And then also advanced computational biology. So the basic scientists here, I'm sure, and in Calgary have these like microscopes that can do crazy things, and so all this kind of stuff. And then we pair that with artificial intelligence and machine-based learning to start developing our clusters, and then we start identifying pathways of injury and develop targets for therapy. Okay. Now, over here are the things that I think are important as well. So the most important are the patients, obviously, and having their understanding and input into these types of research. Our basic science teams, our clinical translational researchers, the clinical translational teams, the specialty clinics and services. And here, this is a small box, but is a massive box. And so includes all of our allied healthcare professionals and all of our multi-specialty colleagues as well. Having a precision lab, but probably the most important things are these ones here, is having buy-in from administration and government to allow us to develop these types of clinic and also have access to therapy. And we're actually super fortunate because we were able, through years of fundraising by a gentleman who we actually treated his father, we're opening a new glomerular nephritis clinic in Calgary in June, they tell me. So we'll say at least September, but it's supposed to be in June, called the Clausen Belushi Precision Kidney Clinic. And the point of this clinic is really to achieve what we're doing here, is this vertical integration of care, but also horizontal integration of care. At the center we'll be opening, we have geneticists, we have dermatologists, we have respirologists, and so really trying to develop a patient sort of focused hub to allow for management of many diseases, but including this. And I decided to call it Precision Kidney Clinic because I didn't want to limit it to just glomerular nephritis, and so we'll have these other opportunities as well. But I think what that's going to allow us to do is integrate care. And ultimately, the goal of precision medicine is delivering the right therapy to the right patient, right? So that's kind of what I hope to do. And if we get back to our gentleman, is if I meet this guy down the road, is not have him go through 20 years of immune suppression, but right out of the gates be able to do a profile and say, you're a cyclophosphamide patient, or you are a bispecific T-cell engager patient, right? Like, can we sort of predict these things and use them in a way that's smarter? So with this gentleman, I think the clear thing that was missing from his therapy is that he never had received rituximab maintenance therapy. So what we did is we re-induced him with rituximab. We did introduce avacopan because he'd been on multiple different agents and steroids. So we wanted to minimize his steroids, but also potentially improve his renal outcomes. And we did use the rapid taper there. We gave him maintenance rituximab every 6 months. and he has entered a complete remission. And I'm very hesitant to ever take this gentleman off rituximab unless, you know, we have a better solution to that. Having done this for a while now, you know, we say, well, rituximab over years, no problem. But you start seeing patients that have received too much rituximab. So I've got a few that have been on Ritux for 8 to 10 years, and they start getting lots of infections, and we can try and manage that with IVIG and things like that. But it seems like over time, people do develop what I would say rituximab fatigue. So my concluding statements then are, hopefully I've demonstrated that ANCA vasculitis is a very complex and heterogeneous disease. And I think therapy continues to improve, but patients continue to be left with consequences of the damage related to this disease and relapses from toxicities and other therapies. I think we're in an exciting time of therapeutic development, and I think really the push for us is to integrate the delivery of our care so that we can identify these patients and figure out how to give them the right therapy. But as with, you know, almost everything we treat, we're really talking about remissions as opposed to cures so far. So hopefully, that's our home. So I work at Foothills Hospital, so you can see why it's called Foothills. It's at the base of the foothills in the Rocky Mountains. So that's my home institution. So thanks for your attention, and I'm happy to take questions. And if you're not or too shy, you can always email me.
So questions from the live audience? It feels funny to a live audience. Sure, Mark.
Yeah, thanks so much for the great talk, Louis. I like your push for precision medicine, obviously aligned with my vision as well a lot. But for us to have therapeutics really in the setting of precision medicine, that needs to be prospectively done for a lot of these. Has there been any push towards developing those sort of trials?
Yeah. So Mark is asking a question about or supporting the idea of pushing for precision medicine, but saying that when we're doing these or introducing these new types of therapies, that we need to be doing it in a prospective way. Is that fair? Yeah. So I think that's a really important point. And I think just even with the development of our precision kidney clinic, our intent is actually to but offer every patient who comes in the possibility to be enrolled and followed prospectively. And we've grounded that in what's called the Target KD project. And so what Target KD is everyone who receives a kidney biopsy is eligible to have that biopsy specimen stored and along with their blood and urine samples, so that we can either utilize that in retrospective analysis or in prospective analysis in the context of therapy. So I think we're cognizant of that, and I think we're in our infancy, but I think in the world there are clinics that would be more advanced in that situation, and certainly I think like in Cambridge would be one of the examples. But I think your point's well taken, is that when we're doing this, we really have to do it in the context of generation of prospective data.
I think you're also asking about when you're going into trials to actually like
use it as
a
right. Yeah. Okay. Sorry. So like at enrollment as well. Yeah. And so part of some of these biomarkers remain, I think, elusive as well, and some of them are not specific. And so, for example, with ANCA vasculitis, there's thoughts that CD163 in the urine actually is reflective of vasculitis and may also be reflective of remission. And then there's MCP1 and things like that. So most of the times when we're running these trials, they'll allow for collection of specimen and then to go back and do another sort of study based on what's come forward. But, yeah.
Sean has a question. Sean, go ahead.
Thanks, Louis. I'm intrigued by the CAR T cells and the bispecific T cells, because like I've looked at this for lupus, and one of the big challenges seems to be the need to come off immunosuppression for a period of time before you do lymphodepletion with something like fludarabine, which then needs to precede, at least for CAR T cells. I don't know anything about bispecific T cells, but which precedes your kind of harvesting of the T cells. And so that's a bit of a problem for patients that have pretty severe disease, which are probably the exact patients you would want to consider for such therapies that have quite significant toxicity risk associated with them. So how do you envision actually operationalizing that in terms of, does that sequence of events need to occur for bispecific T cells, or can you shorten it, or give cyclophosphamide or rituximab or other therapies and then lymphodeplete after?
Yeah, so it's a good question, Sean. So the easy response is I'm not planning to do anything with it. But so yeah, I totally agree with you. And so in patients, for example, who are already on immune suppression, I think this is a big problem with CAR T cell therapy. And I think these programs would have to be set up to actually collect the bloods at the time of illness, but then with someone who's this severely ill, it represents a major barrier, as you're pointing out, because you need to sort of treat them before you're able to generate this thing. So I think it represents a barrier, and I think it's a barrier that the bispecific T cell engager actually addresses very well, because you don't actually need that to occur with bispecific T cell engagement. And also in some situations, they actually would favor the patient being on some immune suppression to mitigate the cytokine storm that can occur in that setting. So I think in my mind, the bypass is going to be the bispecific T cell engager.
So there's Scott Winderfer has a question, so we can unmute him. So he's a pediatric.
Okay.
Okay, Scott, go ahead.
He's muted. He's muted.
You have to unmute yourself.
Good morning, everybody. Thanks, Louis, for a great talk. And to follow up on Sean's comment, I think the role for autologous CAR T cells would be for that relapsing patient, maybe like the one you presented, where you could collect the cells when they're in remission, and then use the cells when they have a relapse after you're done with cyclophosphamide, or when you have the rituximab fatigue. That timeline may be the best time to use those therapies.
Yeah, I think that's a good point, assuming they've come off maintenance at some point.
What's the role of double transplants in the management of? What's the role of double? I don't. Any interest in the use of autophagy in Canada?
Any interest in the use of autophagy? I'm going to claim a bit of ignorance there, but we actually do have experts in that exact process in Calgary. So Dr. Dan Maruve and Justin Chun actually have explored this space quite significantly. So I think this, to answer the question in a simple way, there is interest in Canada, but as a non-basic scientist, I kind of gonna leave it at that.
Sure.
So thank you very much for the talk. I looked at it on the renal pathology side.
Oh, thanks for coming. Yeah.
With these new clinical trials and therapeutics, are there any morphologic markers emerging? Like, kind of what can I add to my report? Hey, this is possibly immune, but there is some immune complex deposition that can help you choose how you're going to.
Yeah, so so the question from our renal pathologist is, are there things in the kidney biopsy morphologically that can help us to further define therapy or suggest potential therapies? So I think this space needs to continue to evolve, and one of the ones where we may see a little bit of benefit is in the patients who have immune complex deposition in the context of C3 as well. So there's a group of ANCA patients that will have some immune complex deposition with low C3s, and the suggestion is that those could potentially be patients where you should absolutely use a medication like Avacopan. But I think that this space needs to grow a lot. And so I think one of our solutions to that is doing this target KD program, so that as biomarkers and such are being developed, we can back correlate it to kidney biopsies and kind of figure that out. But yeah.
Thanks very much for the talk. I was wondering about what your thoughts are about a genetic test. You mentioned it in the Genesis, that's what patient recently that had scissoring with emperor and vasculitis, then also with ANCA, sort of a transplant there. So, unlike FSGS, where genetic testing difference cancer happen injury, I wonder about like future relapse risk, and like the physician about just wonder about your own experience and what you think the future might bring for genetic testing.
Yeah, so Sinead's question is having to do with the role of genetic testing in patients who have ANCA vasculitis, and she mentioned a family that she's been looking after, and that in some diseases there's more interest in ordering genetics versus others, and whether we should be doing this in ANCA. So I have to say, so in general, I've often been quite liberal with ordering genetic testing, and the question always comes back to me, well, what are you going to do with it? And I may not do anything with it actually right now, but I think it provides information for patients, and it gives us opportunities down the road to revisit patients or issues like you mentioned around transplantation. With ANCA vasculitis, I have to say I've not done it a ton. So I think that's probably an area that through this platform that we're going to explore more within our own institution. So I'm in favor of it. I just in ANCA have not done it a ton yet.
Maybe I'll just ask a comment/question. So we talk about good kidney function at 53 mils per minute. That's not good kidney function for a 44-year-old.
Yeah.
And I think we keep making this mistake in nephrology, thinking that if it's above 45, somehow that really, there's a lot of scar there. And so I just wonder, like, what is the thoughts about preventative or additional therapies, non-immunosuppressive, to maintain nephrons?
Yeah, so I think that's a great question, Dr. Levin. So I'm really a firm believer that, these, and this is an obvious statement, but I think we don't always practice this way, is that these patients have an acute disease that we manage and we're kind of happy with it. And when you look at clinical trials, you manage the disease and their GFRs don't decline very much through the course of the trial. But if you follow these patients over decades, they will end up on dialysis from their chronic kidney disease. And so I think, first of all, ensuring they have the best renal recovery that we can give them is important, but also managing the chronicity of it as well. And so, we've actually been using, everyone gets ACE inhibitors, but we've been using SGLT2 inhibitors in our proteinuric patients as well. And sometimes it's, the discussion is around the timing of when you should give the patient the SGLT2 inhibitor. And for me, like, that's not an emergency, right? Whether I give it today or in 6 months, I think once we get them on it, we do, but I think we've been pretty systematic in doing that. And our allied health, so I'm very fortunate in GN that I've got a nurse practitioner who does only GN and a pharmacist who only does GN, and they're very good at making sure that these things are followed and adhered to.
Yeah, no, I guess, I have two patients, one who had ANCA vasculitis, and I thought she recurred, biopsied her, she had severe FSGS secondary, and another one who had IgG4, and 5 years later got proteinuria, heavy, biopsied, and focal glomerulosclerosis. So I think it's really, when you've been in practice long enough, like, they've remitted, and then all of a sudden you think, so I think it's really important. I don't know if we've thought enough about it. I don't know if you have to wait until they're proteinuric. They've lost nephrons in the acute injury, so why not? And that's a study that needs to be done, I think.
Yeah, I think that's the next step for sure.
Okay, bang on 8:30. Fantastic, thank you. You had, counting in the room, you had 100 people. Excellent. So that's fantastic. Don't usually get that. Thank you very much.
Thank you. Thanks so much.